Welcome to this explainer. Go ahead and clock in, because today we're on a rapid-fire clinical shift. We're going to master exactly how to read the clinical cues and act decisively during postpartum emergencies. You know, when a new mother's condition suddenly deteriorates, quite literally, every single second counts. Your ability to see what's happening and know exactly what to do without hesitating is what saves lives. So let's just dive right into it.
Here's our quick agenda for this shift. We're covering reading the cues, hemorrhage and hypovolemic shock, coagulopathies and embolisms, sepsis and infections, postpartum psychosis emergencies, and finally, the lasting human impact. Let's get started.
Section 1. Reading the cues. This is our foundational framework because recognizing that something is off is the very first step in saving a life.
So here's the big question we need to answer today. How does a nurse actually apply clinical judgment when a postpartum client suddenly deteriorates? Normal postpartum findings should always be trending towards stability. But when that stability suddenly flips to an emergency, maybe it's increasing bleeding, worsening pain, or sudden neurological changes, how do we react instantly to protect both the mother and the baby?
Well, we anchor every single emergency response to an exact 6-step rhythm. I want you to think of this as your clinical judgment muscle memory. First, you recognize the cues. Then, analyze what those cues actually mean. Prioritize your hypotheses, meaning ask yourself, what is the biggest, most immediate threat right now? Then generate your solutions. Take immediate action and relentlessly evaluate the outcomes to see if what you're doing is actually working.
Recognizing those cues begins with the classic BUBLE assessment: breasts, uterus, bladder, bowels, lochia, episiotomy, lower extremities, and emotions. Any expected finding that suddenly shifts demands immediate analysis. Say you have a uterus that was perfectly firm and midline, and suddenly it's high and boggy. That requires action. We never ever dismiss these changes as just routine.
Section 2. Hemorrhage and hypovolemic shock. Moving right into our first high-stakes scenarios: severe bleeding and the rapid onset of shock. This is where your rapid recall is absolutely put to the test.
To simplify what can be an incredibly chaotic situation, remember that postpartum hemorrhage is defined as a cumulative blood loss of 1,000 milliliters or more, or hypovolemia within 24 hours of birth. When you're prioritizing hypotheses for hemorrhage, instantly categorize the bleeding into one of the 4 T's: tone, which accounts for a massive 70% of cases, trauma, tissue, or thrombin. Identifying the correct T generates the right solution.
Let's put this into a real-world clinical scenario. Picture this. You recognize a boggy, enlarged uterus with heavy bleeding. You analyze that as a tone issue, uterine atony. So you take action with immediate fundal massage and emptying the bladder. But what if you assess that exact same client and the uterus is perfectly firm, yet there's a steady, continuous trickle of bright red blood? You analyze those cues, prioritize the trauma hypothesis, like a cervical or perineal laceration, and prepare the team for surgical repair. It's the exact same symptom of bleeding, but an entirely different clinical judgment.
Now, if that hemorrhage isn't stopped, hypovolemic shock sets in fast. You're going to recognize the cues: tachycardia, falling blood pressure, low oxygen saturation, pallor, and oliguria. You have to take action by securing large-bore IV access, providing oxygen, and getting a type and crossmatch for blood products. Crucially, you evaluate your outcomes by calculating the shock index and tracking that urine output very closely. If the bleeding slows down and perfusion improves, you know your interventions are working.
Section 3. Coagulopathies, embolisms, and PE. Let's tackle the systemic threats where bleeding and clotting go drastically wrong, moving deep into those thrombin and circulatory emergencies.
The absolute crucial point here is knowing your diagnostics. If you recognize a patient with diffuse oozing from their IB sites and petechia, you are looking at a severe thrombin threat. You generate solutions by immediately ordering specific coagulation studies. With disseminated intravascular coagulation, or DIC, you're going to see a drop on the CBC, specifically low platelets and fibrinogen, prolonged PT/INR and aPTT, and highly elevated D-dimer and FDP. Differentiating DIC from idiopathic thrombocytopenic purpura or von Willebrand disease dictates whether you're about to administer specific factors, steroids, or massive blood transfusions.
Okay, let's look at another critical scenario. You recognize sudden dyspnea and chest pain. You have to analyze these cues rapidly. An amniotic fluid embolism triggers rapid hemodynamic collapse, altered consciousness, and often immediate cardiac arrest in DIC. It requires immediate, massive resuscitation. On the flip side, a pulmonary embolism presents with sudden dyspnea, pleuritic pain, and tachycardia, requiring immediate imaging to confirm, emergency oxygen, and rapid anticoagulation. They're both incredibly life-threatening, but your prioritized hypotheses dictate totally different immediate life-saving actions.
Recognizing cues early is what prevents those pulmonary embolisms in the first place. If you find a unilateral red, warm, swollen leg during your bubble V assessment, you analyze this as a deep vein thrombosis. The most important action? Do not massage that leg. You take action by notifying the provider and requesting a Doppler ultrasound. You evaluate the outcomes by making sure the client is safely anticoagulated and that the clot doesn't migrate to the lungs.
Section 4. Sepsis and postpartum infections. Next on our shift, we face the subtle but incredibly deadly progression of postpartum infections. These cues will absolutely sneak up on you if you aren't hypervigilant.
A temperature of 100.4 degrees Fahrenheit or higher after the first 24 hours is your primary red flag. Specifically, you need to recognize the classic triad of endometritis: foul-smelling or purulent lochia, profound uterine tenderness, and fever. You want to recognize these cues early and prioritize the hypothesis of endometritis way before it has a chance to escalate into systemic sepsis.
Let's see how this builds into our clinical judgment rhythm. We catch the elevated temperature and tachycardia. We recognize the cues. We analyze the source by checking the perineum, the incision, the lungs, and the uterus. We prioritize the risk of sepsis. We generate an antibiotic plan with the provider. We take action by drawing IV cultures first and then administering broad-spectrum IV antibiotics. Finally, we relentlessly evaluate vital signs and the client's response to the treatment.
Section 5. Postpartum Psychosis Emergencies. Listen, emergencies aren't just physical. Acute psychiatric deterioration is a literal life-threatening crisis for both the mother and the newborn, and it requires immediate intervention.
The sheer complexity of postpartum psychosis requires careful analysis. This is absolutely not the postpartum blues, which typically resolve in a couple of weeks with reality testing fully intact. If you recognize delirium like disorientation, abnormal mood swings, paranoia, or frank hallucinations, you must analyze this as a complete loss of reality testing. Symptoms can fluctuate wildly from minute to minute, encompassing severe depression, extreme anxiety, and very dangerous abnormal thought content.
When these cues are present, your highest priority hypothesis is absolute safety. Period. You generate a plan that completely separates the mother and baby to prevent harm. You take action by securing the environment, never, ever leaving them alone together, and obtaining emergency psychiatric treatment. In this moment, safety comes before teaching, before bonding, and before any kind of routine care.
Section 6. The human impact. After the clinical adrenaline fades and the emergency is finally stabilized, we have to confront the holistic reality of these events. The medical crisis might be over, but the human crisis is often just beginning.
The ripple effect of a severe postpartum complication is just massive. Surviving a massive hemorrhage, an emergency hysterectomy, or an embolism leaves deep, lasting scars. It delays that crucial early skin-to-skin bonding, it severely disrupts breastfeeding, it can impair future fertility, and it places this immense financial and functional strain on the entire family system.
We also have to recognize the invisible injuries. The clinical crisis might be resolved, but an unexpected ICU admission leaves a mother with severe trauma symptoms, intense anxiety, and profound grief over altered birth expectations, and the risk for long-term postpartum depression just skyrockets. Evaluation of our patients' outcomes has to include screening for these mental health impacts long after they're discharged.
Because of all this, our generated solutions must extend far beyond the hospital doors. As the source material explicitly points out, the care team must facilitate comprehensive collaborative care. We have to engage social work, lactation consultants, mental health professionals, and spiritual support to help rebuild the family's emotional foundation. We're treating the whole family, not just a physical symptom.
So, I'll leave you with this final thought. When the absolute worst happens, what lifelong difference will your rapid clinical judgment make on a mother's physical and emotional recovery? Your ability to read the cues without hesitation and act flawlessly is exactly what sends a mother home to her family. Just keep that rhythm in mind. Recognize, analyze, prioritize, generate, act, and evaluate. Thanks for joining this explainer.